So my talk today will be on the pathogenesis of exercise intolerance in long COVID. These are the grants that I've received to help support some of the research that I'll be talking about today. So the focus of my presentation will initially describe what the typical clinical presentation of patients with long COVID. I'll reiterate and re-emphasize the pathophysiology of long COVID that has been described by Dr. Joseph and Dr. Sistrom. And then I'll talk about our publications and our work that's ongoing on how we have integrated advanced cardiopulmonary physiology with advanced omics to better understand the aberrancy that begets this syndrome. So the WHO defines long COVID as such. These folks have a broad range of symptoms, which can be physical and cognitive, that develop during or after the acute COVID illness, and they continue for 2 months or 3 months if you take into account the onset of the acute illness, and they have substantial impact on the individual's life, and they're not explained by an alternate diagnosis. The most commonly reported symptoms are exertional intolerance, post-exertional malaise, which is a state where patients have a crash following either physical or a cognitive activity. So our initial understanding of the pathophysiology of long COVID was informed by this paper that Dr. Sistrom and Dr. Joseph has talked at length about. We followed up this small study with our experience at Yale, which had over 50 patients. And I'll briefly describe the findings of that paper as well. This is a level 3 CPAT. I'm not going to get into too much detail because I think Dr. Sistrom has spoken at length about this earlier on. What I'd like to emphasize about the level 3 CPAT and exercise assessment, exercise hemodynamic assessment is to the right of this slide right here, where you see at rest the cardiac output's typically at around 5 liters a minute. In untrained, non-athletic individuals, that cardiac output can go up as high as 20 liters, and in elite athletes, that can go up to about 40 liters a minute. But what I'd like to point out is that you could see that during exercise, the vast majority of blood flow is distributed to the skeletal muscle. So the large blue area amongst the untrained athletes and the athletes, you can see the vast majority of blood flow is directed towards the skeletal muscle. And so when we examine the systemic extraction, oxygen extraction that Dr. Sistrom has described, we're actually primarily looking across the skeletal muscle bed. So during heavy exercise, the vast increase in cardiac output that we observe is directed almost exclusively to the exercising skeletal muscle. And just a point of interest, you can see that the blood flow to the brain remains constant irrespective of the stages of exercise, and that's related to cerebral autoregulation. This is a slide that Dr. Joseph had shown earlier. This is our setup at Yale. We do level 3 CPATs upright or semi-recumbent. In the semi-recumbent patients, we do simultaneous echocardiograms. Similar to the setup at the Brigham, we have a arterial line, a pulmonary artery catheter, where we get continuous hemodynamics, minute-to-minute venous blood gases and arterial blood gases so that we can calculate what the systemic oxygen extraction across the skeletal muscle bed is. And leveraging our expertise in level 3 CPATs, we published our findings, and we demonstrated that these patients have a primary peripheral limit to exercise that is characterized by impaired systemic oxygen extraction. And there are no evidence of heart failure or pulmonary hypertension. The setup at Yale is as such that the patients with long COVID, they get seen in our post-COVID clinic, and they undergo an exhaustive list of investigative testing, which includes echocardiograms, CAT scans, lung function testing. Some of them have coronary angiograms, all of which either are normal or do not explain their exertional limitation. Only then do they get subjected to a level 3 CPAT. All 10 patients here had mild self-limiting illnesses, and the time of onset of the level 3 CPAT from the acute COVID illness was over 300 days. So these folks had symptoms that were going on for approximately a year following the acute mild COVID illness. Dr. Systrom described earlier about the pathophysiology of this exaggerated hyperventilatory response that we also observed in this patient population. And this is the follow-up study that we published recently, looking at our entire cohort of patients with long COVID. And you can see that the vast majority of patients, with the exception of 2 patients who had exercise pulmonary hypertension, the vast majority of patients exhibited a primary peripheral limitation to exercise characterized by impaired systemic oxygen extraction. We also did a sub-analysis amongst those patients with impaired systemic oxygen extraction. We compared those individuals who underwent supervised exercise rehab programs to those who did not. And we did not find a difference in the degree of oxygen extraction impairment. So pushing back against the idea that the impaired extraction that's observed in this patient population is because of deconditioning. We then, decided to look and see, what is it that's causing this impediment in oxygen extraction across this patient population. And our initial study, which we published last year, looked at about 22 patients where we ran proteomic analysis on peak exercise mixed venous blood in these patients with a primary peripheral limit to exercise, these long COVID patients. And what we found was there exists a dichotomy in the aberrant cardiopulmonary physiology and the protein expression in these patients. So in the first, to your left right there is the physiology that we demonstrated during the level 3 CPAT. And what we found was that if we were to dichotomize patients according to the severity of the oxygen extraction to mild and severe, we find that the patients with the milder oxygen extraction impairment had this compensatory enhanced cardiopulmonary response where they had increased or greater oxygen delivery. We also saw a similar dichotomy in terms of aberrant protein expression between patients with mildly impaired oxygen extraction compared to those who have more severely impaired oxygen extraction. So if you look at this volcano plot here, this thing's out now. You can see that in patients who have mildly impaired oxygen extraction impediment, you have this compensatory increase in proteins that are involved in mitochondrial oxidative phosphorylation. Whereas in the patients who had more severely impaired oxygen extraction, you see persistence of proteins that are involved in the inflammatory disease process and in endothelial dysfunction. Now, these are patients more than a year after the acute COVID illness, and the vast majority of patients had mild self-limiting illnesses, and despite that had evidence of persistent inflammation and endothelial dysfunction that contributed to the aberrant pathophysiology that we showed in our CHEST and our ERJ paper subsequently. Before I go into our preliminary results on metabolomics, I thought we could review the ATP generating pathways that are involved during exercise. So it's divided into both aerobic ATP production through fatty oxygenation, glucose oxygenation, and amino acid oxygenation. You also have aerobic energy metabolism that involves glycogen, phosphocreatinine, and purine nucleotide. The second image here shows the relative contribution of the different energy sources throughout incremental exercise testing. And you can see during higher intensity exercises, ATP generation is primarily contingent on muscle glycogen rather than fatty acids. And so what we aimed to then do was to determine the profile of the metabolic signature of long COVID subjects during exercise. So we looked at the differential expression of metabolites in the arterial system and the venous system during exercise across the skeletal muscle vascular bed. And this is, at best right now, this is hypothesis generating. So I'll share with you the prelim results that we've have. So the heat map on your right there shows that demonstrates the arteriovenous differences in various metabolites. And we initially attempted to see if there's any correlation to the initial COVID severity, to demographics, to age, sex, and the BMI, and we found no correlation. On your right here, we looked at individual metabolite profiling. The first slide is actually from the muscle biopsy from the study from the Amsterdam group that showed that at rest, the intramuscular inosine was reduced. What we found during our maximum incremental exercise testing was that you actually have an increase in the difference between the arterial and venous inosine expression between both the patients who had mild acute COVID and those who had severe acute COVID illnesses. We also demonstrated there was an increase in venous succinate release during exercise that was correlated with the individual's exercise capacity. And we'll get into all this a little bit in more detail in the next couple slides. Finally, we also demonstrated that there was a signature towards lactate generations that's dependent on the severity of the acute COVID illness. Now, these are very small numbers. We saw there was an appropriate increase in lactate from rest to peak between both severe and mild acute COVID illnesses, but the increase in lactate from rest to peak amongst the most severely affected folks was somewhat blunted compared to the patients who had milder disease. And so how do we put all of this together? And this is how we, again, I want to emphasize this is primarily hypothesis generating, and we're still looking at more data here. So we know that these folks have normal oxygen delivery. We know that the cardiac output's normal. We know that the hemoglobin is normal. And so the underlying aberrancy that we're observing in this metabolite study resides in the intracellular space. So the first aberrancy that we observe that implicates both the aerobic and anaerobic energy metabolism cycles is that there is reduced mitochondrial ATP and ADP ratio. So because the mitochondria does not generate adequate ATP, there's a reduced need for diffusive delivery from the bloodstream to the mitochondria. So that's what we think first happens. The second thing relates to the purine nucleotide cycle, which the Amsterdam group showed, and we emphasized during dynamic incremental exercise testing. So inosine typically is incorporated into the muscle cells for for ATP generation via the purine nucleotide cycle. We observe a large AV difference at peak exercise, suggesting that inosine is being imported into muscle cell to help support ATP generation. We demonstrated that lactate release was impaired in the most severely affected folks. We found that there was a correlation with reduced peak venous lactate expression amongst the severe COVID versus the mild COVID folks. And finally, we also showed that there was an increase in succinate release, and succinate formation occurs primarily in hypoxic condition in anaerobic states. We demonstrated that peak venous succinate correlated significantly with peak exercise capacity, suggesting that peak venous succinate could potentially reflect as a useful biomarker in patients with long COVID. So going forward, so we've established that, these folks primarily have a systemic oxygen extraction abnormality. And yesterday, you brought up, how can we apply this level 3 CPAT? Is it applicable, across different institutions, across different countries? And it is a technically arduous procedure, and so we decided to look and see if we can come up with a non-invasive way where we can not only diagnose but perhaps repeat it subsequently to allow for interim pharmacotherapeutics to assess the response to treatments. So we came up with a contraption right here. So this is a setup in our MRI suite, where if you look, this is my drawing of someone's leg, where the leg is outlined by the thighs outlined, and then the lower limb of the leg is outlined by the blue highlights. And then there's a pulley at the very end of it, and you extend and flex your leg. That's demarcated by the red highlights, and the magnet sits on the top of the thigh, and what it looks for, it looks at the decay of phosphocreatinine. And you look at the earlier slide I had, phosphocreatinine is actually utilized in the very early stages of exercise, in the rapid phase of intense exercise activity. And we looked at a patient who had acute COVID but does not have long COVID clinical manifestation. This is someone who had acute COVID and recovered. And this is the expectant decay from rest to exercise and to recovery, where you have the rise in phosphocreatinine, where you see the expectant decay of phosphocreatinine during initial rapid exercise in someone who does not have long COVID. We hypothesize that patients with long COVID will demonstrate a much more rapid decline in phosphocreatinine because of their reliance on anaerobic energy metabolism, with slower recovery post-exercise. And then we also hypothesize that the rapid decline and slower recovery of this phosphocreatinine will be associated with the impaired oxygen extraction and resultant reduced exercise capacity. So in summary, impaired systemic oxygen extraction and the subsequent utilization underlies the pathophysiology of reduced exercise capacity in these patients. Impairment in both aerobic and anaerobic ATP production underlines the pathobiology of the impaired extraction. And the integration of multiomics analysis allows for the ability to correlate advanced physiology with molecular pathobiology, and perhaps hopefully help address the need for more precise treatment approach in this patient population. This is my acknowledgement slide. In the bottom right there is David Systrom, without whom there's no Yale exercise physiology lab. There's no Yale pulmonary hypertension. So Philip Joseph does all the procedures, so he takes the credit for that. And this is the team back home. Thanks.
Well, thank you very much for all these excellent presentations that actually pinpoint the problem of the complexity of these diseases. It's really, really obvious after hearing your work and interpreting all this huge amount of data and this fantastic hypothesis that we are facing a very complex disease. It's very interesting because each one of you is looking at slightly different ways of this thing. And but for patients, I think the most, and that's going to be my first question. The floor is open for questions, of course. My first question would be, I think that for patients, one of the most important things is that get this disease out of exclusion criteria to inclusion criteria. What am I saying here? I'm saying that if we could have a biomarker or a physiological test or an imaging test, doesn't matter, that it would be pathognomonic of this disease, that would be a major step forward. Now, my question is very simple. On your lines of research, do you think this will happen soon? And if you think it will happen soon, what kind of diagnostic tests should we expect for this coming, I don't know, 5 years? And I'll put that question to you, David, and then to all of you also. Is a functional test, an imaging test, a biomarker? Because that's why I think it's very important here.
Is this on?
Yeah.
So I'll maybe speak broadly. Imaging, I'm not so sure. I mean, most of the conventional imaging we think about are heart and lungs, and although there are abnormalities in subsets of patients with mostly long COVID, I'm not sure that will be a scalable screening device. I do think Indy presented some nice data on proteomics and metabolomics, and we have some similar data. What I would say about those entities is that most in the business with those blood-borne biomarkers as diagnostic tests in a variety of diseases require a lot of patience. And what I think is special about some of Indy's work, and perhaps what we've done as well, is the exercise perturbation, and I think you just alluded to it. It decreases the numbers for statistical significance necessary. So it really ratchets down the N necessary to determine whether a given blood-borne biomarker is significantly different from normal individuals. So I think the prospect of ultimately of a scalable screening device and a diagnostic test might combine some low-level exercise test like the SHAPE test that we've talked about and a blood-borne biomarker, whether it's proteomics, metabolomics, transcriptomics, lipidomics, on and on it goes, the inflammasome, or even a combination of those blood-borne things. But I think the exercise perturbation really helps move this whole area, out of requiring thousands of patients to determine whether something's significant or not. But,
You're talking about the non-invasive pulmonary testing.
Or maybe minimally invasive.
Or minimally invasive, okay.
Exercise
Okay.
test
Okay.
with a peripheral venous.
Okay. All right. Thank you.
Yeah, I would agree, and the symptoms of long COVID and ME/CFS may be broad and non-specific, but the setup that we have is as such that when they come to see us in clinic, they have these symptoms, and they have all these unremarkable conventional investigative testing, and by that virtue, we can already predict almost with certain certainty that these folks will have the aberrancy that we describe on the level 3 CPATs. But how do you extrapolate that to other setups, right? Where they don't have the setup that we have, where they undergo the entirety of testing. So some level of some exercise testing where you can invoke neurovascular dysregulation in the periphery, coupled with the blood biomarker for example, succinate that we described could be very useful in this setting, I feel.
But again, I agree with David because we need a lot of patients in order to identify subgroups of patients and risk stratification among the samples. We need a lot of patients.
Yeah.
What do you think?
I do, and the other thing I'd like to say is that the patient population that we see it's a very specific patient population in long COVID, because long COVID also encompasses those who have sequela from the acute insult. So some patients have, fibrotic lung disease from severe pneumonia and ARDS. They also, they also are lumped in the long COVID category, and then you have patients who have, airway hyperreactivity as well, and dyspnea. This is a very specific cohort of patients.
Okay, thank you very much. Philip, you want to say something concerning this? Okay. All right. I'm going to open the questions, but first I would like Nuno Sepúlveda to actually ask your question, because I can't read your handwriting.
My question is to Philip. I think you already highlighted that
Give him the microphone, I'm sorry. No, the microphone.
Yeah, I agree with all that you said, about that we need more data, and I'm going to tackle a little bit on my presentation. But I was just wondering that in one of the studies, you guys used the National Academy diagnostic criteria, and I've seen that it seems like you had like a very low number of patients that reported an infection as a disease trigger. Is that right? Like around 25%. And my question is that we see more like 75% is actually the other way around. So my question is more like, are the results generalizable for this other population?
Yeah, I mean, I think just in full transparency, we did not. That was basically the preceding infection was chart review. It wasn't a specific question we asked the study cohort. It was a retrospective review, so it might be underrepresented. So I wouldn't say it could very well be over 30% there.
Okay, we have more questions? Please, Dr. Laura. Then you, okay? You first, then.
Well, thank you very much for your excellent presentations. I'm fascinated with your theory about crosstalk between muscle, lung, and heart or cardiovascular system. There are any histological or morphological marker for that low rate, hypothesis of low rate neural terminations in the muscle or not?
Do we have pathology related to what we think is a systemic vasculopathy, in this case, the failure to venoconstrict? There are animal models, and I think it was alluded to in the other two talks, and I probably didn't give it fair representation, that suggest, in addition perhaps to the dysautonomia, we have talked about autonomic nervous system dysfunction, that especially in long COVID, but perhaps in some patients with ME, there is an endothelial abnormality. It could be endotheliitis, inflammation of the endothelium itself and its interaction with a smooth muscle underlying it. The microclots that were alluded to yesterday are also very likely significant in terms of pathogenesis in a subset of patients, maybe more frequently, I think Sulevine alluded to this, more frequently in long COVID, but also described in ME. So these are little packets of clots that get into the microscopic vasculature. They are loaded up with pro-inflammatory cytokines, and when they're released, they inflame the endothelium and perhaps contribute to its dysfunction. And there's even a line of thought that red blood cell interaction with the endothelium could be at play in some patients. The red cells, both in ME, CFS, and in long COVID are too big, too stiff. Rheologically, they don't get through capillary beds normally, and they also don't interact and vasodilate appropriately. So there could be some patchy perfusion abnormalities in the microcirculation, leading to impaired oxygen supply. So a lot of different lines of thought, mostly from animal models, but some human, that suggest an endotheliopathy from those pathways.
Thank you. And then you. With that, please. First there. No, that's all right. We respect the order of call. No problems. It's just a couple of
So
minutes.
thank you so much. Fantastic panel. I think you increased my knowledge so much about this exercise intolerance around COVID-19 or long COVID. There's been some descriptions, especially in CPAT level 1, of dysfunctional breathing in this patient population. My question is, do you see that? This is something that we should look at. This is really a marker of long COVID, and it's probably simpler than all. There are very sophisticated kind of studies. And the second is about lung function, more simple lung function basic data. What about lung diffusion? I've seen a lot of patients with normal lungs, normal heart, but still there is a lung diffusion that is low than expected. And what do you think? Is this also a marker of some endothelial dysfunction, and how do you see that in the future for phenotyping and also for following the therapies and so forth, because it's so simple to do a lung function test, right?
So maybe I'll be brief and leave time for my co-speakers here, but we're aware of the Donna Mancini paper that described dysfunctional breathing with a level 1 non-invasive CPAT, and we agree, and I think I'll be interested in the Yale experience. We occasionally will see what appears to be oscillatory breathing, and not certain of its genesis, whether it's part of the dysautonomia pattern. We don't think it's classic heart failure in most patients, and we don't think it's pulmonary hypertension, which is less commonly associated with that. I will actually address the DLCO, which is interesting, and it's something that we have talked a lot about. The upright DLCO, where gravity is the enemy for the patient with dysautonomia with presumptive blood pooling in the legs and the abdomen, there is a similar topographic pressure gradient from top to bottom of the lung in the upright lung. And we observed this hemodynamically in our upright exercise testing. I'd emphasize you lose all of this if you go supine. And we've known forever from John West's work that in tall individuals, especially, the apex of the lung may be perfused only during systole, and it's a de facto dead space area. Alveolar dead space is increased, it's not perfused. Our hypothesis is that because in a subset of individuals with both ME and long COVID, the input and outflow pressures to the lung and out of the lung are so incredibly low that the apex of the lung is de-recruited, and those capillary beds are de-recruited, and that's what we're catching on the decreased DLCO when everything else looks normal, the CAT scan. We would clearly differentiate, though, these patients from those with parenchymal lung disease. And I'm aware of a paper that just was released yesterday or the day before using hyperpolarized xenon gas of the lung that described diffusion abnormalities. But if you look carefully at that one, the most severely affected patients with long COVID had ground glass opacities on the CAT scan that went with it. They had parenchymal lung disease. The vast majority of patients that we see with invasive CPAT have really perfectly normal pulmonary gas exchange. They don't have abnormalities, even at peak exercise. The AA difference, the alveolar arterial O2 difference, is normal. And usually the VDVT, the dead space to tidal volume ratio, is normal.
I don't think I have much to add to that, honestly. I agree. I mean, we do observe the reduction in the LCO, and for us, sometimes it's a telltale sign that they have this. In a reduction in the LCO with normal spirometry, normal lung volumes, and a normal CAT scan, that's a telltale sign for us that these folks probably have this as well. Yeah.
Right. Thank you. Dr. Dora?
Thank you. First of all, thank you for your excellent presentation. And one thing that I was asking is just asked by Professor Carlos Wink. And I want to ask you two things, simple things, I hope. One thing is, we all see that in long COVID, we have got people of different ages, different comorbidities, and you have spoken that just before. I want to ask you if during that studies that you expose patients to effort to middle and more effort exercise, you have ever seen not an hypotension, a postural hypotension hypothesis that was pre-said before, but arrhythmia, some cases of arrhythmia, because there are two major importance factors for the arrhythmias. Not only the exchange in PCO2 and O2, and diffusion and the shunt, but also because of the cardiac output that you have said before. And some patients have already cardiac pathologies, some have heart cardiomyopathy pre-existing. Have you seen these kinds of pathology in that context? And the other question is, we have told about metabolics seen in blood cultures and in blood samples, and about phosphorus, potassium, magnesium. Have you saw every kind of alteration in these patients with long COVID that was potentially a biomarker, because phosphorus is one of the markers, it's one of the dosable measurement metabolic in the blood that sometimes we saw in long patients with COVID that is above the cutoff. Okay. Have you saw this alteration? Because phosphorus is also a metabolic that makes fatigue, alterations in the nervous system. Have you find this?
So the first half of the question was related to, do we observe arrhythmias during exercise? And in our very specific cohort of patients, we don't observe any abnormal heart rhythms during exercise. We are aware that a lot of these patients report palpitations, irregular palpitations. A lot of our patients, before coming to us to see the level 3 CPAT, actually get extended Holter monitoring. And what we see is that they have an SVT rhythm. They don't have any atrial arrhythmias, and presumably that's a compensatory heart rate response that perhaps is related to low filling pressure state to increase the cardiac output. You have low stroke volume, so to increase the cardiac output, you develop an SVT rhythm as a result during activity. But we have not observed it during exercise in our cohort. The question about phosphate and phosphorus is an important one. We know that it's important for diaphragmatic function, for example. We did not observe any aberrancy in phosphorus metabolism in our metabolomic studies, no. So.
Thank you. We have a question for a patient that I'm going to, Maria Ramos. Please do, I can't read your handwriting, so will you please ask yourself the question? Thank you very much. Está aí.
I was diagnosed in Brussels 13 years ago. And a year and a half after starting the treatment, I was diagnosed with Lyme disease. And last month, 2 more bacteria were found, Babesia and Bartonella. I'm feeling better 2 years from now. And my question is it possible to recover from MEA Lyme disease up to 85%, as doctors told us?
Thank you. Who wants to answer?
I think tick-borne illness and illnesses are a well-described precipitant, presumably for ME/CFS, and it predated the long COVID clinic or long COVID phenomenon. And I don't hold myself out as an expert. Susan Levine, who has ID expertise, may comment, but I'd ask her to. But we collaborate with infectious disease physicians at Mass General, in particular Donna Felsenstein, and we inherit patients who have been treated for tick-borne illnesses who have had some success with the treatment of ME/CFS. I think predicting how full a recovery any individual with ME/CFS is difficult. I would say on the hopeful end, we've had cases, phenomenal cases, of patients who've been treated and have realized full recovery, really what they would view as their normal selves. And at the other end, there are less robust responses. And I think one of the things we as a group have to do moving forward is stratify our treatments, really enable precision medicine, and predict what's going to work for any individual. So I wouldn't give up hope, and because we have had phenomenal success on many occasions. And Sue, do you want to comment?
Microphone is coming, Susan. Just.
Yeah, hi. I agree with David that there are some people who have had success. And I think, unfortunately, and I always say this, that we don't really know who our successes are, because if they're not ill, they don't come back to us. And so they're lost to follow-up. But I believe, particularly in cases of Lyme, and it's been reported in long COVID, that there may exist a reservoir in the gut bacteria of COVID particles, and possibly in some cases, Lyme or other tick-borne illnesses may reside in reservoirs either in the gut or in the brain and cause kind of a perpetuation of symptoms. And I'm not sure what the right approach is to get rid of them, or if there should be like a low-level maintenance therapy as a potential clinical trial in some of these patients.
Thank you. Dr. Rink.
I would like to go back again to exercise physiology and talk a little bit about lactates. The lactates dynamics that you see in these patients are different from other disease entities. And I've seen in social media a lot of patients having their own lactate sensor and measure it on a regular basis to drive their exercise. Do you think that is useful? Do you find that there is some different changes in lactate in this disease compared to others? And what would you recommend to this patient to use that to, monitor their pacing, and what would you recommend?
Yeah, well, I'm not familiar with the lactate sensors, but in terms of the lactate differences in this physiology, we do notice on occasion, I think, two things that might signal maybe a more mitochondrial dysfunction phenotype of these patients. So one is delayed lactate clearance after exercise. So 1 hour after exercise, we draw a repeat lactate level, and normally it should normalize or clear 1 hour after exercise. And sometimes these patients have delayed lactate clearance, implying a mitochondrial dysfunction. And we pair that with, at least in the lab at Brigham and Women's, venous oxygen tension at peak exercise, VPO2. That should nadir around 27 millimeters of mercury, and these individuals are higher, 30. So again implying maybe mitochondrial dysfunction and a different phenotype. In terms of lactate, I'll let the panel maybe answer about the lactate monitoring or guiding exercise.
Yeah, I'm not sure. Pass it to Indy, who actually presented some primary data on lactate. We're forever asked what's a normal peak exercise lactate, not so germane to monitoring in the field. And the answer is wildly discrepant. It depends on your mother and how many fast twitch muscle fibers you inherit that are glycolytic and produce lactate. There are some modest changes. I think the Amsterdam group suggested that the fast twitch muscle fibers can be modified some as a result of disease, and that's been shown prior as a result of detraining. It's a complex business. But normally at one end of the spectrum, lactates at peak exercise in a marathoner can be 2 millimolar. And normally a sprinter of the world, if that was your mom, could be 15 millimolar at peak exercise. And it may influence to a degree the recovery kinetics. One other thing I'll just mention that we've seen anecdotally is some patients with ME and long COVID arriving at the lab and their very first resting lactate is elevated, and unusually so, and they're not hypoxemic. So we see a lactate of 2 or 3 at rest, and they've done no exercise yet. I think I would agree with Philip. That might be a marker of mitochondrial dysfunction.
Yeah, so I just want to, so that I think during exercise, lactate is not a bad thing. Right? So some degree of intracellular acidity facilitate tissue oxygenation delivery from the Bohr effect. So to use lactate as a surrogate to how much you exercise, I don't know what the threshold is, but the concern with lactate arises from if you have a high resting lactate, that's abnormal. If you have a high lactate even at rest an hour after exercise, that's abnormal. But during exercise, I don't think it should be viewed as a bad thing necessarily. So with that said, I don't know how you're going to use, what the utility of a lactate sensor to guide exercise. Because what degree is abnormal, we don't know. In fact, it's beneficial to have some degree of acidity.
Okay, we have time for one more question. Luis?
I had one here.
Oh, I'm sorry. After that, lady, it's okay.
Okay.
Please.
So I had a different question, but I just have to mention we're some of the patients that are leading that lactate study through Twitter. So it's hashtag the acid test. And we collected data from hundreds of patients. Todd Davenport is helping us with it, and those results should come out in about a month. So look out for that. I'm glad that somebody mentioned that. My question is, you mentioned a lot of, you're looking specifically at exercise, but, I'm a patient, and we have symptoms even at rest. I'm having symptoms right now, just sitting here, and some of the patients are, severe, very severe. They have symptoms just lying in bed, and those symptoms can get worse from just trying to communicate or cognitive exertion. So I'm curious what you think is going on there with what you have found.
I think maybe if I paraphrase the second question loosely, we are very much aware there's a range of severity of disease, including those who are suffering and bedbound and homebound, and at the other end there's less severely affected cadre of patients with both ME and long COVID. And I think if you are absolutely right, our focus and our is often exercise-based and what limits you on with exertion. So what is the answer if you're miserable at rest? And my broad answer would be, and I don't think this is too wildly out there, inflammation. And inflammation is what makes you feel like you have the flu. And it begets all sorts of symptoms, including cognitive. I think blood flow may play an abnormality, may be part of the story at rest, but maybe not all of it. I think systemic inflammation. We have some unpublished data with the intramural NIH that looked at a 40 multiplex cytokine profile and activation of the inflammasome. It's the so-called TRAIL pathway. And for those who don't know, TRAIL is ubiquitous. It's a cytokine released from all sorts of cells in the body in response to virtually every perturbation you can think of, including all the things that precipitate PEM. And we have some preliminary evidence with exercise that TRAIL goes up abnormally in ME, and the inflammasome is activated abnormally in ME compared to normal controls. This isn't at rest. This is mostly related to exercise. But I don't think it's too wild to extrapolate a bit from those data that this is about unbridled inflammation and all the symptoms that go with that.
We have data to show even at rest, there is abnormal upregulation of proteins involved in the inflammatory pathway. What I presented earlier was the exercise data, but those proteins were elevated even at rest. And when we compared, and you don't, even at rest, the extraction is abnormal in these individuals. It's more enhanced during exercise. For example, you can calculate the difference between the arterial venous extraction, and you see that it's abnormal at rest. Even during regular resting right heart catheterization, we see elevated mixed venous saturations, also implying that the extraction is abnormal even at rest, supine. And how inflammation relates to that, inflammation itself can affect mitochondrial function. Inflammation can alter the caliber of the vessels and cause impediment in oxygen diffusive delivery. But no, inflammation is present at rest even in our patient population.
Thank you. Final question to Dr. Nakul. Make it short, please, Luis.
Okay, just a very brief comment and a question. The comment is, if you look at the literature on ME/CFS from the past, you see hyperventilation as being frequently described, but the most common explanation had been anxiety. So very refreshing to hear about your more thorough explanation about causes and hyperventilation, how this can be related to symptoms in ME and long COVID. My question is, you hypothesize that small fiber neuropathy is behind abnormalities in venous return and etc. However, the data that I saw you showing didn't show a relationship between small fiber neuropathy in biopsies, skin biopsies, with the outcomes that you measure. So do you have any comments on that?
Yeah, I think Philip showed the scattergrams that were related to other biomarkers that we looked at during invasive CPET. They were VO2 peak, cardiac output peak, oxygen extraction, and the filling pressures. We have not actually gone back to look at small fiber density and compare it to the propensity for hyperventilation yet. So it's a great suggestion and one that we ought to do. The other thing that I think Philip said very quickly is that that original paper in 2021 relied on a single epidural biopsy. We have since done a deeper dive into small fiber neuropathy with a second biopsy up by the hip, which is deeper in the Peter Novak Autonomic Lab at Brigham Faulkner, and captures sweat glands. And if you get sweat glands, then you can look at the true autonomic fibers innervating the sweat gland, whereas the other ones may just be nociceptive fibers. So we're hoping that a better look for small fiber neuropathy, including sweat gland innervation, might provide some more insight into the pathophys of both the hemodynamic abnormalities and hyperventilation.
Right. Thank you very much. In the first part of the morning, we discussed physiopathology. Applause, please.